I'd just like to start by saying hello and welcome. My name is Shane Griffiths and I've been asked to talk to you about stroke. Stroke is classified as a cerebral blood supply mismatch where cerebral vascular accident has occurred resulting in impairment or loss of brain function. Stroke is a leading cause of disability and the second highest cause of death in Australia. Tissue damage due to blood supply interruption to the cerebrum is rapid and requires fast intervention to be corrected before irreversible damage occurs. Time is brain, marking the importance for all clinicians to be educated in recognition, treatment, and ongoing care for stroke patients. We are going to explore the clinical manifestations of ischemic stroke that have been highlighted through the pathogenesis utilizing the case study of Mr. Marks. Mr. Marks is a 65-year-old male admitted to the emergency department with severe right-sided weakness, right-sided facial droop, incomprehensible words, a GCS of 11 out of 15, right hemianopia, and a history of hypertension. In Mr. Marks's case, the middle cerebral artery that branches directly from the carotid artery, branching off supplying blood flow to the left hemisphere of the cerebrum, including the basal ganglia, the temporal lobe, and the parietal lobe, as well as some deeper structures, has been impaired. As the MCA has a vast supply to the cerebrum, a multitude of symptoms may present. As a result of the middle artery impairment or occlusion, within a few minutes, cell death occurs. Due to the decrease or loss of oxygen, glucose reducing or inhibiting the production of APT causes an ischemic cascade effect. The lack of APT production causes neuromitochondria to switch from aerobic to anaerobic metabolism. Lipolysis is initiated as a second energy source. However, this is not as efficient, causing a decrease in energy. The sodium-potassium pump within neurons ceases to work, causing calcium and sodium influx and potassium efflux, and a depolarization of the cell. Water enters through passive diffusion due to the increased sodium stretching the cell. Consequently, cytotoxic edema follows. Calcium continues to build within the neurons, stimulating the release of glutamate from presynaptic transmitters. Glutamate then binding to postsynaptic transmitters excite neighboring neurons. The excessive concentration of glutamate eventually excites neurons, causing cell death. The ischemia is divided into two parts: the ischemic core, which is characterized by the immediate area of the injury, or the severe ischemic tissue described by Hoving as a decomposition to relative cerebral blood flow of less than 30%. Residual oxygen and glucose is consumed by the core within minutes, causing necrosis. Tissue distal to the ischemic core, known as the ischemic penumbra, is ischemic but still viable due to utilizing neighboring arteries called collateral arteries to obtain some sort of oxygen and glucose. If blood perfusion is not established, further tissue degeneration becomes notable and sections of the brain become impaired, causing motor and sensory disturbances such as hemiplegia, facial droop, and speech difficulties. A Glasgow Coma Scale was performed when Mr. Marks was admitted, assessing his clinical signs concerning neurological functioning. Mr. Marks is opening his eyes to voice and sound and verbalizing incomprehensible sounds, but obeying commands, giving him a GCS score of 11 out of 15. As Mr. Marks is able to comprehend instructions, this indicates he is experiencing expressive aphasia known as Broca's aphasia. The Broca's area, found in the inferior frontal gyrus of the dominant hemisphere in the cerebrum, are responsible for facial muscles and speech production. In contrast, the Wernicke's area is located in the left hemisphere in the temporal lobe, responsible for speech comprehension. Impairment of the Broca's and Wernicke's area is responsible for Mr. Marks' facial droop and aphasia. Mr. Marks is experiencing right hemianopia, characterized by loss of vision right side of the vertical midline, and is caused by deficit to the optic tract that shows involvement with the parietal lobe due to impaired vision perception. This is caused by lack of blood perfusion supplied by the middle cerebral artery. Importantly, the brain consists of two hemispheres. The nerve tracts called the corticospinal tract cross over, which means that the left hemisphere of the brain controls the right side of the body. This is why Mr. Marx's injury to the left side of the cerebrum manifests clinical symptoms as right-sided hemiplegia. Mr. Marx is presenting with right-sided weakness, indicative that there is ischemia to the motor cortex. The motor cortex, located at the rear of the frontal lobe, just before the central sulcus, separating the front from the parietal lobe, responsible for voluntary movement. The basal ganglia are found deep in the frontal part of the brain, encompassing the striatum with the motor cortex, and are perfused by the middle cerebral artery. As the basal ganglia are responsible for follow-through or refined movement, Mr. Marx's right-sided weakness may also be due to the basal ganglia being compromised, presenting as abnormal posture. As cranial PaCO2 rises, the cranial autoregulation system compensates by vasodilation, trying to correct oxygen deficit. However, increased blood volume increases the cranial pressure, contributing to early mortality within 24 to 48 hours. As the cranium vault is fixed, with limited space for expansion, the Monro-Kelly hypothesis states that there is 3 compartments within the cranium vault: the brain, the blood, and the cerebral spinal fluid. Taking this hypothesis and applying it to this scenario means hypertension will increase intracranial pressure. Due to the increased blood volume or pressure, Mr. Marx is of high risk of cerebral bleed. One of the other compartments must compensate, and usually the first will be the cerebral spinal fluid, as it's quickly reabsorbed. As there is a decrease in cerebral spinal fluid, vasoconstriction of the vessels within the cerebrum aims to reduce cranial blood volume, aiming to reduce pressure and correct compartment imbalance, maintaining cerebral homeostasis. However, as ischemia is not resolved, the cycle continues. Pressure increases until it reaches arterial pressure, reducing arterial flow, and bilateral cranial hemispheres become impaired. The cranial manifestation will start to present as restlessness, confusion, or decrease in consciousness. Here is a fast mnemonic in recognition of stroke: face, arm, speech, and time. Thank you very much.